we are going to discuss this new drugs in ophthalmology. See, first of all, getting new drugs in any specialty is a big thing because so much of money is pumped into R&D, and we have here we are going to discuss a few drugs. Okay, a class of drugs that you know are new. One is anti-VEGF. So anti-VEGF is not that new now because it's almost 2 decades since we've had anti-VEGFs. So what do you think is the new class of drugs that we're going to discuss today? So we're going to talk about tyrosine kinase inhibitors. Now tyrosine kinase inhibitors, you very well know in other specialties, especially your cancer chemotherapy, you know about tyrosine kinase inhibitors, TKIs. What was the first drug that came as a TKI? It was imatinib. I hope all of you know that. Now, in ophthalmology, it has been used starting with sunitinib. Now, all of you know sunitinib? Yes. But sunitinib, yes, it has been used. Now, we have even more drugs which we use in ophthalmology. So, first let's discuss the mechanism of action. So, those of you who have joined in late, we are talking about tyrosine kinase inhibitors. So how is it different from anti-VEGF? So basically they're all used in either diabetic retinopathy or ARND, the neovascular type of ARND. Now how does it work? See, do you actually know how anti-VEGFs work? All of you know about Lucentis. You heard left, right, center about Lucentis, Avastin, then the eccentrics, all these drugs, the intravitreal anti-VEGFs. But you actually know how anti-VEGFs work? See, anti-VEGFs prevent the ligand receptor binding. So I'll just make it a little simple for you. So we have these VEGF receptors. Okay, so we have 3 types of VEGF receptors: VEGF R1, 2, 3, and 5 types of ligands. So 5 types of VEGF we have: A, B, C, D, E, right? So the binding of the ligand to the extracellular domain. So this is your cellular membrane. So the extracellular domain ka binding is inhibited by your anti-VEGF drugs. So all of you know about various anti-VEGF drugs. So today's video is not about anti-VEGF drugs. So when this is inhibited, the further actions of VEGF is not happening. But VEGF is not the only one involved in the pathogenesis of proliferative diabetic retinopathy or the neovascular ARND. You have other molecules, not just VEGF. We also have what is called as PDGF, that is platelet derived growth factor. We also have FGF, fibroblast growth factor. So all these factors are involved, and we also have what is called as PEGF. Then you got angiopoietin. So many molecules are involved. So if we can inhibit somewhere downstream where all these converge, all these molecules or all these receptor actions converge, if we can block somewhere downstream within the cell, that would be a great option. So that is what your tyrosine kinase inhibitor does. So where does your tyrosine kinase inhibitor act? See, can you see these receptors? These are your VEGF receptors. Then I've just put it as P to show you there is a PDGF receptor. So these molecules, when they act, when they bind, the ligand binding to the receptor, so downstream, there's going to be angiogenesis. You know that's what happens in neovascular ARND. You have new vessels, choroidal neovascularization, and PDR. You got retinal neovascularization, right? And we also have this fibroblast growth factor receptor. So when this is activated, then it results in fibrosis. So that is why you got the membrane formation in PDR. You got the disciform scar in case of neovascular ARND as a complication. So all these are involved. So now this tyrosine kinase inhibitor is going to inhibit the downstream intracellular signaling. So even if the ligands manage to bind, yes, still the downstream activity will all be inhibited. Is that clear? So but we don't want to do a monotherapy. Till now the trials that have been done, mostly it is a combination of anti-VEGF along with the tyrosine kinase inhibitors. Okay, so do you also know any other molecule which acts on 2 ligands? okay, I'll give you the answer. So one is on VEGF and also on angiopoietin. It inhibits two. So that is your faricimab. That is also new, but right now it's not that new. Okay. So faricimab, it's quite much in clinical practice now. So now this tyrosin kinase inhibitor, tyrosin kinase inhibitor, that doesn't block your angiopoietin. So angiopoietin still continues to act. Now what are the drugs? So the drugs, we have used sunitinib before. Now what are all in the clinical trials now and which have quite a good efficacy is axitinib, vorolanib and your lenvatinib, right? So these are all given as intravitreal injections. So you got vorolanib, lenvatinib, sunitinib, which is already being used, and also your axitinib, right? So these are given intravitreally. Now some drugs like sunitinib and even this vorolanib have been tried orally. Yeah, it's wonderful, no, when somebody can give you orally rather than giving an injection into the eye as intravitreal injection. So it's great. You just have to pop in something. So oral also have been tried. Now the problem with oral is there is a complication. There is this complication of serous fluid getting accumulated in the retina and also some healing problem when the patient has a retinal detachment. A rhegmatogenous retinal detachment, they operate and then it's not healing well. So these are the side effects of giving it ocularly. Yes, intravitreally is a standard one that has been tried with all these drugs. So these are the drugs. So what are the drugs? You have axitinib, then you have vorolanib, lenvatinib and sunitinib. That was the earlier drug, which was actually the first drug tried in ophthalmology. Now what are the indications of tyrosine kinase inhibitors? The indications are diabetic macular edema, diabetic macular edema, then neovascular ARMD, what you call as wet ARMD, but the present nomenclature is neovascular ARMD, characterized by CNVM, choroidal neovascular membrane, and also for diabetic retinopathy, both NPDR and PDR without diabetic macular edema. DME is diabetic macular edema. They've also tried in myopic CNVM as well, but these are the three standard ones. And but trust me, these are all not FDA approved. Okay, these are not FDA approved. So this is the mechanism of action and tyrosine kinase inhibitors, because with the INI-CET coming, you can have some eccentric questions like this. They may ask you what is the side effect of an oral administration of tyrosine kinase inhibitor. Which of the following is not an anti-VEGF? You know the traditional anti-VEGF drugs. So remember these names which are used in ophthalmology. Yeah, imatinib is there, but imatinib is not given intravitreally. Okay, it's not given for an ocular indication. So these are things that I wanted you to know. I hope those of you who joined late. Yes, so this tyrosine kinase inhibitor, it's going to act on the intracellular domain of the receptors. Now again, to recall, your anti-VEGFs, they prevent ligand receptor binding, whereas your TKIs, they prevent the further downstream signaling. So of which all pathways? One involving your VEGF, then your platelet derived, where is that? Platelet derived growth factor and fibroblast growth factor. Okay, so it's got a very good effect. So far so good. So I will see you again at 9 p.m. where we will discuss the quiz questions. All right, any other doubts guys in this? So make a small note of whatever I told you. I will try to give you a flashcard. I will put it up either on Facebook or Instagram. And in spite of me giving you a flashcard, please do make notes, because when you write, your memory improves. When I write, only my memory improves. Yes, any other doubts or any other questions? Any other questions? I can't see anything in the comment section. So I will wind up this session. I hope you found it useful. Okay, so go through this again, make small notes, write down all the names of the drugs, because it's way too much, your immunotherapy kind of drugs. All right guys, see you